Hi, everybody. Good evening, good morning, good afternoon, wherever you are. Welcome to this IACH roundtable discussion dedicated to the 19th annual meeting of the International Myeloma Society, which was held in Los Angeles between the 25th and 27th of August 2022. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, and I'll be joined for this roundtable discussion brought to you by the IACH by a distinguished top faculty and top expert in this field. Obviously, we have Professor Perrault from Toulouse, Professor Costa from University of Alabama, Professor Manier from the University Hospital of Lille, Professor Touzeau, University Hospital of Nantes, Professor Facon, University Hospital of Lille, Professor Harousseau from the Cancer Institute in Nantes, and we will be joined, they are in the clinic in a few minutes, by Professor Mateos from Spain, but also Professor Nupur Raj. So as you are probably familiar with this type of activities, after every key meeting of the discipline of the field, the ICH would organize this kind of roundtable discussions in order actually to summarize, but also to digest the flow of information and get the opinion of the panel and the experts on the key take-home messages. And I'll try to structure this discussion based on the way the IMS program, the IMS Congress program was structured. And interestingly, the organizing committee did really an amazing job, almost 1,700 participants in person and several hundreds virtually. So they have identified 6 key topics where there were some seminal lectures followed by a few abstracts selected among the abstracts submitted to the Congress. And then there was a sort of a debate about the hottest and most controversial issues. So the 6 topics identified and discussed during this Congress were about first disease monitoring, management of high-risk multiple myeloma, induction for newly diagnosed multiple myeloma, management of relapse multiple myeloma, immune reconstitution and vaccination in multiple myeloma, and last but not least, cellular therapy. And all the experts participating to this roundtable discussion actually were key contributors to this event. And of course, I'd like to take also the opportunity to mention that there were several sessions for oral abstracts, and there was also a plenary abstract session. So let us start from the beginning, and I would like to discuss first with all of you the topic of disease monitoring. And when it comes to disease monitoring, we heard about imaging, of course, the value of PET scan, the value of MRD, which is becoming more and more important. But also, I think for the first time, there was some very interesting discussions about mass spectrometry and how this can be used in addition or even in replacement to some of the invasive techniques. So maybe I can start, and again, I do apologize. I will distribute my questions depending on the images I see on my screen. So let me start by you, Salomon, and what are currently the recommendations for disease monitoring as a standard of care?
Yeah, so we have the IMWG criteria published in 2016 to assess the response and also the MRD of patients with multiple myeloma. So we have two techniques approved by this recommendation. One is the NGS MRD assessment, and the second one is the flow cytometry. The depth of response is 10 to the minus 5. We know that we can go to the 10 to the minus 6, but sometimes it can be difficult for some patients. So at 10 to the minus 5, we are able to evaluate most of the patients, which is value. And you have either a single time point where you evaluate this MRD, or we have what we call the sustained MRD negativity. There are discussions between 6 months or 12 months, but IMWG recommended 12 months sustained MRD negativity, so 2 time points with a 1 year apart. So this is one thing. You mentioned the imaging, and it's more and more important. We know that even when we have an MRD negativity in the bone marrow, we can have extramedullary disease as well. So PET-CT is becoming a very useful tool to assess the MRD negativity and make sure that you don't have this EMD beside the bone marrow evaluation. So that's very useful as well. So we now have this NGS or flow cytometry / PETs CT negative or positive MRD negativity, right? So that is very useful. Now, as you mentioned, more and more we are looking for tools that can be detectable in the blood by a simple blood test, and not doing bone marrow or of the patient aspirates of the patients all the time. And the interest in mass spectrometry in the last years is truly interesting. So there are 2 different types of mass spectrometry that we can use. The one called MALDI-TOF, which is kind of the easiest to perform in the lab, and one with liquid chromatography mass spectrometry, which is a little bit more complicated and needs more expertise of the team. But we see very interesting data. We can probably discuss this, but if we were summarizing, it's a very useful tool. It's close to what we can achieve with bone marrow NGS and flow cytometry as well. Perhaps it's a little bit less sensitive yet in the blood, but it's probably very useful, and we can repeat, of course, the time points much easier than in the bone marrow. So this is something that is now applied into clinical trial to try to truly evaluate the prognostic role of this MS evaluation of MRD.
Thank you. Excellent, Salomon. Luciano, how is it on the other side of the Atlantic when it comes to using MRD and monitoring with MRD, and whether you see an added value for mass spec development?
Thanks, Mohammed, for having me. I would say in the US, as many of you know, a lot of the care of myeloma patients is still done outside the academic institutions, essentially by general oncologists, not by myeloma experts. So the uptake of new diagnostics tends to be a little bit slow. There is a kind of greater acceptance and greater use of marrow-based MRD in academic centers. But I think for the majority of patients being treated in the community, that's still very, very uncommon. I think of course, we are always, hoping to refine prognostication. I think that's what all those assays eventually try to do. And I think it's clear that mass spec is mostly, but not fully overlapping with marrow-based MRD. I think the value of that is likely going to be very context dependent. I mean, since it's essentially the detection of the paraprotein at a very low levels, I do not expect that to be very useful early in the disease treatment, just due to the very long clearance of the protein. But I think we're gonna refine and find a better use later on, both in maybe identifying patients who still have disease that does not, that can forgo a marrow-based therapy. And as we get better upfront therapy and create cohorts of patients who are observed without therapy, that might be one way to monitor disease resurgence short of full relapse that does not need a frequent marrow sampling. But I think it's important. I think it's important to keep in mind that without that being said, marrow-based MRD is where we have the most data. So I think we need to construct the use of mass spec, but without losing the anchor, using the reference to marrow-based MRD.
But Cyril, don't you think that if we are able at some point to improve the threshold and the sensitivity of mass spec, it can replace MRD, because there is this invasive, let's call it like this, bone marrow aspiration related to what we do, how we do MRD today?
Yes, for sure. Mass spec is very attractive in reason to the non-invasivity of the test, for sure. And the last data from the Sebia test, for instance, they reached nearly the 10 to the -6 sensitivity. So yes, I think it will be very important to test mass spec in the context of prospective trials and to compare with NGS MRD. But yes, for sure, it's a whole body. It's not only bone marrow MRD. So it's very attractive for sure. But I think, as Salomon and Luciano said, we have all these prognostic factors, MRD NGS, MRD NGF, TEP-CT, now mass spec, that are the prognostic value is confirmed by prospective trials. But I think the next step is what can we do? Do we have to change our treatment based on residual disease results for our patients? And I think this question is not answered yet. And we have prospective trials that start to try to answer these questions. And Luciano presented the results of the master trial. We have the ongoing MIDAS trials. And for the first time, I think we try to adapt the treatment of patients based on MRD. And I think this is the next step. We know the prognostic value of MRD, of sustained MRD. We have to move on. And as it is done for patients with DLBCL or acute leukemia, MRD is the key test to change treatment. And we have to move on in multiple myeloma based on these tests.
So let me ask a practical question to you, Aurore. Today, not tomorrow, today in your practice, how do you, when do you use MRD, and how frequently you do it, if you do it, and when do you use PET scan, and how frequently you perform it? And I'll ask the same question to you, Thierry, in an elderly patient, whether all of these monitoring techniques are needed.
So today I use MRD monitoring for patients treated by autologous stem cell transplantation, and I use both PET-CT for the MRD outside the bone marrow and NGS because Hervé and Gilles perform MRD every day. We don't use MRD to adapt treatments except in some particular situation. For patients with high-risk myeloma, sometimes we use MRD to guide, to adapt the second transplant or the consolidation, but it is not for all the patients.
Excellent. So Thierry, in an elderly patient who's, let's say, 80 years old, and I'm sure you have pioneered a superb treatment allowing these patients to live long and well, with the combination of Daral and Dex. Do you need MRD? Do you need PET scan?
I would say we need PET scan. To be honest, I have to confess that I am not using routinely MRD in this particular patient, I would say. But I think I would probably do PET scan, let's say, once a year or something like that. So the way to assess bone is just for us to do PET scan at certain time points, and then it's a little bit okay. You have to decide, but I think it's fair to say that if you evaluate bone once a year, that's an acceptable approach for the routine practice. But with the DRD regimen you mentioned in a 80-year-old newly diagnosed patient, I have to say that even if we reach complete response, which is the case for 50% of patients, I do not see a very strong interest in looking at MRD. So you could disagree with that, but that's my clinical routine practice, I would say.
Okay, so let's ask Jean-Luc about his opinion on whether he would favor using these techniques, because you mentioned that obviously you don't use it to stop the treatment, but obviously one of the key issues our patients are struggling with is the continuous duration of therapy, its morbidities, and I'm not talking about the cost, issues. So how can we handle this issue, Jean-Luc, assuming these techniques become available and easily feasible?
First, I'd like to make a comment on the mass spec issue. I think that currently with the MALDI-TOF technology, the sensitivity is not enough. And I don't think that it is a usual tool for MRD assessment currently. The Spanish group has an experience with flow cytometry showing that in the blood, it's possible to detect, of course, at a lower level of sensitivity, but if it's positive, it's not necessary to perform the bone marrow assessment. So having said that, I'd like to try and answer your question. I think that we are changing our mind about the interest of MRD assessment. Until now, it was mostly useful for prognostication, and now is becoming a tool for deciding the treatment. But it's mostly within clinical trials. And I appreciate the comment, Luciano's comment about the real life, because in the real life, we still don't know how to use MRD assessment result to decide the treatment, to monitor, to tailor the treatment. It's a question for clinical trials. So for clinical trials, yes, we have to perform all these, to use all these tools, MRD assessments, repeated times, PET scan, in order to define the objective of the trial, which is MRD, sustained MRD, and then to decide if you can continue the treatment or change the treatment. But again, it's mostly for clinical trials. And I'd like to finish by saying that MRD assessment is useful if we have the objective of curing patients. If we have the objective of curing patients, we need to obtain sustained MRD negativity. So to repeat MRD assessment, you need to have PET scan negativity, and again, to repeat PET scan. But I think that for a number of patients, you can have very good results, very long progression-free survival without obtaining MRD negativity. And this is a lesson from the Maya trial. For elderly patients, the proportion of patients achieving MRD negativity was less than 30%. And yet, the progression-free survival was more than 5 years. So for those patients, maybe we don't need to cure by trying to obtain MRD negativity. We can just have the best treatment possible for the long time, and I would say with a better quality of life and with a very aggressive treatment. That was my comment. Again, we are trying to cure patients. It's with more and more drugs, more and more expensive drug, prolonged treatment, so it's more and more expensive. And one critical question would be the duration of treatment, which cannot be assessed without MRD assessment, but again, within clinical trials.
Excellent. Thank you very much. And I kindly remind everybody that you can send your questions through the Q&A chat box. And if I don't take them immediately, don't worry. I'll try to sneak them when we will reach, the right topic for these questions. Luciano, you wanted to add something here.
And I just want to make a quick point regarding the comment Professor Harusa made is, I think the MRD can be a little bit of a divisive topic, but I think it's much easier to agree on how we're going to use MRD is to agree that we need to develop strategies for response adapted therapy. And I think, MRD is just the tool. And at this moment, maybe the best.
You are a pioneer.
but the reality is near 100% of the evidence we rely on is based on treatments that we keep everybody on until they progress or they complete a finite milestone. While in reality, we know the response to therapy, whichever way you measure, is the best indicator how they're going to do. So it's a shame that we don't instrumentalize that more often.
Excellent, thank you. So let's move now, and I think one of the topics discussed during IMS was maybe, at least for some colleagues, the capacity of MRD negativity to overcome the baseline high-risk cytogenetic features. In another word, the dynamic assessment of the risk. And that brings me to the management of high-risk multiple myeloma. And my first question will go to Cyril. Today, Cyril, and based on what you heard during the IMS Congress, and outside clinical trial, because of course, guys, it's quite easy to always say, well, we want to do trials. But as Luciano mentioned, and it's true in every place, majority of patients, unfortunately, are not always included in clinical trial. So what is the definition of the high-risk myeloma for you today? And what is the standard of care of these patients?
Yeah, that's an important question. I think to date, baseline cytogenetic is still a key prognostic factor, and 17p deletion, T414, chromosome 1 abnormalities are clearly associated with a poor outcome. But we learned from several prospective trials that MRD could overcome the impact of baseline cytogenetic. And when we look at the IFM 2009 trial from the IFM, we can see that patients with high-risk cytogenetic that achieved MRD negativity have a good outcome. And it has been confirmed by the EMN02 trial, the EMN trial, patient who achieved negative MRD, even if in the presence of adverse cytogenetic at baseline, they have a good prognosis. So I think to date, we don't know. And again, I think prospective trials such as the MIDAS trial will bring key strong answers to this data. But to date, we consider patients with a 70p deletion, T414 plus 1 chromosome 1 abnormalities as patients with adverse outcome. And I think for young patients, we could consider tandem transplant in addition with a quadruplet induction and consolidation. And I think for elderly patients, anti-CD38 plus Lendex is still the gold standard, even if in the presence of adverse cytogenetic. I know some of us would consider quadruplet for these high-risk patients, and we will have the results of IMROSE and CEPHEUS phase 3 trials that tested quadruplet treatment with anti-CD38 in elderly patients. And I think to analyze the results of patients with high-risk cytogenetic will be very important.
So Thierry, the question to you is about what is the standard of care of a high-risk cytogenetics elderly multiple myeloma? Again, my famous 80 years old patient who is fit and well.
It's the same. I could say it's basically a daratumumab-based regimen, and I would probably say that it's basically the so-called DRD regimen. In fact, when you look at DRD, and there will be an ASH abstract for that, DRD has a quite strong benefit in terms of PFS versus lenalidomide and dexamethasone, and it has also some benefit in terms of overall survival. So the other point is just to say, what would you like to do? Could you have another treatment proposal, I would say, and so that I still recommend to stick to the DRD regimen. And so if patients are not frail, the question would likely be to use the combination of CD38 and VRD in the next few years. So if you, at the time we will be able to manage isatuximab or daratumumab VRD, and if the patient is able to tolerate this regimen, I do believe this will be probably the best we could do for patients with high-risk cytogenetics before the availability of new immunotherapies.
Professor Arousseau,
yes, I think that Thierry just answered my question. I wanted to ask him about the effect of daratumumab in high-risk cytogenetic in the Maya trial, because the difference between Dara-Revdex and Revdex was less significant in patients with high risk. So probably daratumumab Revdex is not the top solution, and if elderly patient can tolerate Dara RVD, it might be more effective in the case of high risk cytogenetics. No.
So this is a question for you, Thierry, whether one needs
to comment the result of the Maya clinic regarding high risk cytogenetic, with the difference between Dara-Revdex and Revdex was not very significant, even in the middle.
The question is about adding a proteasome
the Forest
inhibitor
Plus, it was in the middle.
high-risk cytogenetics.
You mean the question is to adding
a proteasome inhibitor in the high-risk cytogenetics, whether this would be useful or not?
That we don't know. We could speculate that it would possibly be good, but for that we have to wait for, as you know, the two major phase 3 studies having isatuximab or daratumumab in combination with VRD, so the so-called IMROSE and CEPHEUS study. So at the time we will have the 1,500 patients of CEPHEUS and IMROSE, we may be able to say that the benefit for patients with high-risk cytogenetics will be present or not that much, so that we don't know. But if you can manage either daratumumab or isatuximab VRD, this is not the case for the vast majority of countries. In fact, you may say that for an elderly fit patient, this regimen could be potentially the best you could do, but we have no clear data to support this at the present time.
So that brings me to a couple of questions from the audience about where it looks like that people have the feeling that in a standard risk you use bortezomib, and in a high risk you use carfilzomib, a second generation proteasome inhibitor. So assuming we have a young and fit high risk cytogenetics patient, Aurore, what do you think? I think most of the trials agrees on anti-CD38, daratumumab, Elotuzumab, but it looks like to me that they tested KRD, not VRD. So what are your thoughts on this? What can we say? For sure, it doesn't do harm, you know, to have a second generation protein inhibitor. The question is this a recommended approach?
I would say it is not a recommended approach for now, because there is no demonstration of superiority of CARF on bortezomib, especially in phase 3 studies, and we can discuss about the Clarion study, about endurance, but I think in the context of clinical trials that have an objective to adapt treatment based on MRD, we observe that carfilzomib-based regimens provide more deep response and more MRD negativity rates. So it is why we use carfilzomib in that regimens. But I'm sure we can't say today that carfilzomib we have to use carfilzomib for high-risk patients.
Excellent. No, I think you provided a balanced and I think reasonable answer. So while we're staying in this high-risk myeloma population, Salomon, a question for you. And we have several questions about this. One of them is from Professor Beksak in Turkey. Hello, Miral, how are you? And this is about actually the double auto in high-risk multiple myeloma, obviously fit patient. But I will expand and extend this question to the issue of actually using the novel immune therapies, because this was debated during the IMS Congress, is using, for instance, bispecific consolidation or even CAR T cells as consolidation after a single auto. Any thoughts on this, Salomon?
Yeah, so we don't exactly know, right? Because the trials are just starting, so difficult to truly speculate on what will be the best. The assumption in a kind of biological point of view is that perhaps the immunotherapies will be less selective of the high-risk subclone of tumors than the chemotherapies, such as the tandem autograft stem cell transplantation, and that perhaps we can abrogate a little bit the poor prognostic of high risk using immunotherapies. Well, this is kind of hypothetical and speculation, and we need, of course, to see what happens with clinical trials. So as you mentioned, there are several clinical trials that are starting, ongoing, evaluating CAR T cell, for example, instead of autograft stem cell transplantations. This is CARTITUDE-6 in frontline transplant-eligible patients. There are trials, and one from the IFM, led by Cyril Touzeau, evaluating the place of bispecific antibodies in patients who don't reach MRD negativity after autograft stem cell transplantation, and perhaps we need to give them a little bit more than a simple lenalidomide maintenance in those patients. So there are trials designed like this, and yes, we will need to see in the specific subgroup of high-risk patients if there is an even better improvement of outcome in those patients, because perhaps we will be able to reach to destruct the high-risk clone as much as the standard risk clones.
Excellent, thank you. Jean-Luc?
Yes, I would like to come back to the first question, definition of high risk. What is the role of defining risk? The first role is, of course, for the patient and for the doctor to know what is the prognosis overall. The second role is to compare trials and to better evaluate new strategy, new drugs. But it's also becoming more and more useful to tailor the treatments. And I think that currently it's very difficult to tailor the treatment if there is no consensus regarding the high-risk population. And I hope that in the near future, the International Myeloma Society will succeed in organizing a meeting of all the experts to, at last, define the group of high-risk patients. For the time being, we have several stratifications, the simplest being the RISS, which is not good. We have the French one. We have maybe the one which is developed by the EMN and which is maybe the most easy, the easiest system, the RISS2 with the 3 abnormalities that were mentioned by Cyril. But I think that really it's an emergency to define which are the patients who are who have a high risk cytogenetic. I would like to add one point, which is clinical. I think that extramedullary disease is very important for defining the prognosis. And finally, I finish by saying that for the time being, since we are not able to reach a consensus regarding the definition of high-risk disease, the best way is to use the dynamic assessments and defining the high risk by the results to the induction treatments. Luciano in the master trial showed that the high-risk patients remain the very high risk, double hit remain high risk. But I think a good way would be the Midas trial and other ones, which define the high risk by the response to a very good induction treatment using a modern quadruplet. And if a patient does not reach complete MRD negativity at this -5 level, it can be considered as a high-risk patient, whatever the cytogenetics. So the dynamic assessment of prognosis is becoming more and more important for defining the rest of the treatment.
Excellent. Thank you very much. That brings me into a question for you, Luciano, and actually several people were alluding to this, but I'll take the one from our friend Arthur. It's always difficult to pronounce it. Juricin from Poland. He's very always loyal, very great friend, organizing some nice events.
Arthur.
And the question, Arthur in French. Okay, good. That makes my life easier. So today, what would be in your center, Luciano, the induction you use in a high-risk patient? Is it Dara VRD? Is it Dara KRD? Is it Elotuzumab KRD? Is it Dara VTD? And maybe you can give us a flavor about your ongoing trial using bispecifics for consolidation, because I think this is what people have been debating and discussing at some point.
Yeah. So you know, great, several things there. So what we use for induction for both standard and high risk currently is Dara VRD. Do I think K is a better drug than V? I do. Is that more important in high risk? Yes, but due to you know, insurance coverage situation, if I'm put in a position to choose between getting a quadruplet with V or get a triplet with K, I'll take a quadruplet with V. I think the issue of high risk is I think we have to you know, try to stay open-minded to this. While the definition is very complicated and variable, I think if you talk to 10 experts, you get 10 definitions. I think the one thing we have to be open to is that very notion of risk is going to change as their therapies change, right? And we have seen this in other diseases. We have seen that in myeloma. Things that were prognostic back in the days of melphalan-based therapy may no longer matter nowadays with triplet and quadruplet. And we saw on master trial, and we saw some very elegant data presented with from the Forte study, our colleague Matthias from Italy, showing that patients who become MRD negative, beyond that point, what seems to affect the risk of recurrence is whether they have 2 chromosome abnormalities versus 1 or 0. So that if we're gonna split the population, it may not be between standard risk and high risk any longer, maybe between ultra high risk and the others, which was exactly what we saw in master. I mean, the people who had an isolated 17p deletion or isolation 414, they did just as well as patients with standard risk, including the ones who ceased therapy and went on without any maintenance. We're going to see the same data very soon on the Griffin. The split seems to be between ultra high risk and high risk. Now, those patients are likely to all be MRD positive at the end of induction. We saw that on master. I think we're going to see that on MEDAS and others. So they're going to fall on those MRD positive cohort at the end of induction, where different approach needs to be tried. It's not just a matter of continues the same therapy. We saw this with on Forte. They still do poorly. They relapse despite continue often quadruple therapy. And we saw that on Griffin as well. The data is still to be presented. So what we're going to try to do is to be activated at some point in the near future. Everything is set up minus deactivation, is to explore DARA Rev versus teclistamab DARA as a consolidation and maintenance on those patients. And the MEDAS trial is going to help us answer about double transplant. And I think I really applaud other initiatives that are looking at specific CAR Ts, identifying that early combination of ultra high risk and persistent MRD positive as the window of opportunity to try something new.
Excellent. So we have a lot of questions, dear colleagues. Unfortunately, we can't take them all, especially when you submit cases, specific situations. I do apologize, we won't be able to take them. So I have to make a sort of a summary of some of the questions. So Aurore, a question for you. If you have, because I think you gave the plenary lecture about induction during this IMS Congress, and that was really beautiful. It was amazing. You did a great over and comprehensive overview. And the question here, if you have a myeloma patient, assuming standard risk, not high risk cytogenetics, but with extramedullary localization at diagnosis, how would you handle this patient?
The question is for patients who have only an
No, they have a true multiple myeloma, but then because you do PET scan frequently, you found a significant, bone extramedullary localization.
So I think for now I will not change my induction combination. I will use a quadruplet with DARA VRD in outside clinical trials. I will monitor the EMD with PET CT every 12 weeks to be sure that the response is not only on the biochemical component, but also for the extramedullary disease. And I will perform 1 or 2 transplants, depending on the other high-risk characteristics. So I think if there is only one EMD and without high-risk cytogenetics, and if the patient is in good response, I will consider only 1 transplant and then consolidation and maintenance. But if the patient has other high-risk features, I will consider double transplant.
Excellent. Okay, wonderful. Let's take one last question about induction before we move to the relapse topic. And there has been some debates at the IMS Congress about that bortezomib has become a generic, lenalidomide is a generic. So this VRD combination is becoming, let's say, highly affordable in many places. So let me start with Thierry. This is a famous debate between whether we should give VRD in the non-transplant eligible patient, but the question can happen also in induction for the transplant eligible. Maybe Cyril, you can prepare an answer for this. So the role of VRD, Thierry, versus DARA-RD, and how do you view this? I mean, I personally consider that, you can fly first class DARA-RD. If you cannot afford it, well, VRD is really a great option, and this is how we should envision things, but I may be wrong.
Thank you, Mohammed. I did not hear you very well. But your point is well taken. It seems that the cost of the VRD regimen with both the lenalidomide and the bortezomib generic is something like $10,000 per year, which is very, very low compared to DRD, DVMP, even KRD and for sure for drug regimens as well. So then, you also have to keep in mind that the first line is not the entire treatment, in fact. So those patients who will receive VRD in first line will receive a CD38 for second line, third line, or both. So they will be exposed for a long period of time to CD38 antibodies as well. So at the end of the day, what we should have in mind from my point of view is not only the cost of the first line of therapy, which will be for sure much lower for VRD with generic as compared to other CD38 based regimen, but also at the end of the day, what will be the cost for 2 lines or 3 lines or 4 lines of therapy? Because in the majority of countries, not in all countries, but these patients will receive either daratumumab or elotuzumab or even both. So that said, it's from if you don't look at cost, if you look at efficacy, basically what is true for sure is that the median PFS for either VRD or KRD or even ixazomib lenalidomide index in older patients is approximately 3 years. And then when you look at DRD, the median PFS is approximately 5 years. So your benefit in terms of PFS is about 2 years, which is a quite long period of time for older patients. So that's the efficacy. It's much more. DRD is much more effective as compared to VRD for the older patients. But and then we still don't know regarding overall survival. What is expected for DRD is that the median survival will likely be approximately 7 years, but we don't have strong data with VRD in older patients, and so we will see. But from my point of view, I would likely stick to the fact that we have to use the best option in frontline, and if you have access to daratumumab in frontline, I would go for DRD. Even so, I know that the difference in terms of cost is a huge difference.
Excellent. Thank you very much, Thierry. So Cyril, when do you use VRD today in your practice? Because it looks like in the induction regimen in the transplant eligible, we switched to quadruplet. Dara-VTD is approved. Dara-VRD is highly used by many people. Even Dara-KRD, Elotuzumab KRD are really now becoming very popular regimens. So when do you use VRD today?
So today, as you said, Mohammed, the only approved quadruplet induction in transplant-eligible patient is Dara-VTD, based on the Cassiope trial. It's the only phase 3 trial with such result with quadruplet. So to recommend quadruplet, I think there is only Dara-VTD based on this phase 3 trial. But for sure, we at the results of Griffin phase 2 trial, and the DARA-VRD arm is very attractive with very good MRD negativity rate, excellent PFS. And we are waiting for the Perseus trial that tests DARA-VRD in this context of transplant-eligible newly diagnosed myeloma patients. So DARA-VRD is for sure very attractive, and we use DARA-VRD outside of clinical trial in our daily practice based on this result, because when you look at grade 3-4 peripheral neuropathy, there is no difference between DARA-VRD and DARA-VTD, Cassiope versus Griffin. But when you look at grade 2 peripheral neuropathy, and I think grade 2 peripheral neuropathy is very important for patients for sure, and DARA-VTD induce higher rate of grade 2 peripheral neuropathy. And the other point is cost, of course. And a couple of weeks ago, when we used Revlimid, the lenalidomide from Celgene BMS, the cost for one cycle in our center was 4,000 euros. And since lenalidomide is available through a generic way, the cost is 50 euros. So I think in terms of cost, there is no issue now in French centers to use VRD. And I think we have to wait results from the Perseus trial to confirm, but I think probably DARA-VRD will be the standard of care as a quadruplet induction for newly diagnosed myeloma patients. But I will talk about carfilzomib now. We have very interesting results with quadruplet with carfilzomib. And we have, the German GMMG trials dedicated to high-risk patients, Elotuzumab KRD, 6 cycles. And in this population of high-risk patients, the overall response rate is nearly 100%, with 60% of patients achieving MRD negativity at the end of induction. So clearly, KRD plus anti-CD38 is an excellent combination for this patient. And the IFM trial dedicated to high-risk transplant-eligible patients showed very good results as well, with 80% of complete response rate at the end of induction with 6 cycles of DARA-KRD and 62% of MRD negativity rate at the threshold of 10 to the -5. So we have increasing results with KRD plus anti-CD38. And we have the Ischia EMN trial, KRD versus KRD Elotuzumab, that will probably show the superiority of ISA plus KRD versus KRD. And maybe in the next months or years, we could have approval of quadruplet with carfilzomib in the front line. But so far, we have no approval. So it's difficult to recommend.
Thank you very much, Cyril. That was a very nice summary. And I'd like to welcome Professor Baylis from Calgary. I know you were busy in your clinic, so welcome, Nizar. And thank you for joining us. And Professor Facon had a commitment, so he had to leave. But all of this was planned, guys, no surprise. So we'll continue with our superb faculty. And let's move now to the relapsed multiple myeloma. And this is where it's like a firework, I would say. So today, I think what we already heard, lenalidomide maintenance is being given to almost everybody, whether transplant eligible, non-transplant eligible. So the question at time of relapse, we're facing a lot of patients who are len refractory. So what are the options, Salomon? And here, maybe I want you to go a little bit out of the box and give us a flavor about whether the new IMiD cell modes like iberdomide or mezigdomide can play a role in the len refractory patient in maintenance. What is eventually the role of maintenance with bispecific, sort of a long maintenance, 1 year or 2 years? And whether CAR T cell consolidation will make the job and we can stop maintenance. So lots of questions, but I mean, this is to everybody also.
It's a long
You're going to be next.
it's a long program. I have to say that we had a very nice overview by Nizar Balis actually on the LEN refractory patients. This is, probably one of the most important challenges that we have to face in clinical practice, those patients with early LEN refractory relapse, because we know that they don't do very well. Well, if we try to summarize, we have some, former options with daratumumab, Velcade, dexamethasone, the CASTOR trial, and carfilzomib, dexamethasone, the Endeavor trial, that were the only option until recently, basically. And we now have more and more options, of course, with the combination of anti-CD38 and carfilzomib, dexamethasone, Dara from the CANDOR trial, and isatuximab from the IMSIMW trial that offer clearly new options. Are they different? It's been discussed a lot. Well, Nizar showed us that probably there is no difference between the two trials, and we can, always observe differences with different cohorts, but they are not comparable exactly. So probably very comparable result from this anti-CD38 KD, which is perhaps the preferred option in patients who are LEN refractory, but not anti-CD38 refractory, of course. And then the question is, do we need to switch the mechanism of action? So PI is a good option, or can we actually overcome the LEN refractoriness with new generation of IMIDs and using pomalidomide, which is, of course, an option. We have the Velcade pomalidomide dexamethasone option from the Optimism trial, which is a useful regimen. It's well tolerated as well for elderly patients. So, and even if the patients are DARA refractory, on the top of being LEN refractory, it's still useful. So it's still a useful option. We have the Isakedi on Icaria, but Icaria is supposed to be after 2 prior lines of treatments and not at first relapse. So something that we know can overcome the LEN refractoriness of patients, and we have interesting data, but it's supposed to be at 3rd line of treatments. And then we have all the new options, but we don't have much yet strong data and approval with all the regimens you mentioned, the new IMIDs. We know that iberdomide or CC-92480 perhaps can overcome some LEN refractoriness. Nizar had showed us this. They have a stronger affinity to cereblon and can potentially overcome some sponge effects based on the protein that they will degrade. So that can be an interesting option as well. And the new generation of immunotherapies that so far are for LEN refractory patients, but for sure trials are ongoing at early relapse, and they for sure will become a very important option. So trying to summarize, but maybe Nizar, I can give to Nizar if you want to comment more.
So Nizar, how do you see the future of the management of the LEN refractory patient, given all the available options? Salomon mentioned the anti-CD38 based monoclonal antibodies plus pomalidomide or plus carfilzomib. There is also this famous PVD combination from the Optimism trial. But there is, in my opinion, the future, I believe. So where do you see all this?
Oh, thank you, Mohammed. Again, apology for being late. Solomon summarized the data very nicely. But as you said, a more futuristic look at the future therapies we have available is very positive. We had a quick look at the data as far as CAR T-cell therapy from the CAR-T2 trial, I think was cohort A or B, the one looking at patient refractory to lenalidomide and progressing within 12 months. And in that paper, the most recent update presented by Dr. Herman Isley did show that the median PFS of these patients was excellent at 2 years, well over 70% at 2 years. And that pretty much seemed to be superior to any other data we've seen as far as LEN refractory population. The other data with the novel cell mod also looks very promising. Solomon did mention briefly the mezigdomide or CC-92480 data. in patients who have multiple line of therapy, up to 4 or 5 lines of therapy, including LAN, POM, and that are refractory, we've seen an overall response rate of 50% in the phase 1 trial with the extended data. The median PFS still short in this population with mezigdomide doublet only with dexamethasone, but I can only imagine that adding monoclonal antibodies combination will look very promising. And lastly, obviously, bispecific antibodies targeting BCMA, FcRL5, GPRC5D. Again, the data in this population looks very, very promising in multiply relapsed population with the median PFS ranging around 12 months. And now with earlier studies, as with doing with teclistamab, with the MajesTEC-3 trial, or with elranatamab combination trial with early line of therapy, I think the results yet to mature, but obviously we're going to see much more impressive and durable responses than we've seen with the current regimens we have available to us.
Excellent. Thank you very much, Nizar. So I'll make a little bit as a transition with the immune therapies and cellular therapies. And my question to you, Jean-Luc, do you feel, or do you believe, or do you envision that the bispecific antibodies, but also the CAR T cells will allow us maybe to get rid of this concept of continuous therapy and treat patients effectively with these agents?
You mean out of the relapse refractory status?
Yes, I mean, in both cases, you know, because in relapse refractory setting, we give long-term, you know, until progression.
Yeah. I think that there is a major difference between CAR T and bispecific. It's the duration of treatment. CAR T is one shot, possibly repeated. Bispecific, you have to continue the treatment. And I'd like to ask to the other experts a question which is important for me. Is it possible to use bispecific antibody for a long period of time without increasing the exhaustion of the T cell compartments? If the answer is yes, okay, it will be possible to use bispecific antibody for a long period of time, if we don't consider the cost, of course. If the answer is we don't know, I think that we should be prudent and maybe design trials comparing continuous therapy versus interval therapy. And there is a paper in Blood regarding the exhaustion of T cell with bispecific antibody in acute lymphoblastic leukemia, but it might be the same for multiple myeloma. So I think that we have to learn more about the feasibility of long-term treatment with bispecific antibody before saying that it will be the solution for the long time.
So who would like to take this, Luciano?
I couldn't agree more. Of course, we don't have the answer to that. But I think when you have agents with that much activity, as we see of bispecific, particularly in earlier lines of therapy, it begs the question whether patients need to be on permanently. And some of those agents and some of those programs are developed to be fixed duration. I remember from the top of my head, for example, cevostamab is meant to be 1 year of therapy. That's how they are developing. Of course, the issue with continuous therapy is, as Professor Russell mentioned, is you can have loss of efficacy because of T cell exhaustion, but you also have the concerning issues of T cell functional immunosuppression that predisposes to infection and hypogammaglobulinemia. So I think there's a very strong argument to look for for shorter durations of therapy.
No, I think you nailed it very nicely, Luciano. And by the way, I'd like to announce that we are currently, the ICH Steering Committee, currently working on building an educational program specifically, I think, dedicated to immune therapies. And we will tackle all of these new things because it's a learning curve, about how to manage the risk of infection, how to avoid T cell exhaustion, and so on. We have a question here because we are in the relapse setting from our friend in Brazil, Dr. Vania Hungria. Hello, Vanya. Asking a very relevant question about the role of Elotuzumab, actually, because Elotuzumab was, one of the two first approved antibodies in relapse refractory multiple myeloma. And recently, we've seen the data of Elotuzumab Pomdex. It was even a survival advantage. So who would like to comment on this? Maybe Cyril, I saw you're shaking your head. Any role of Elotuzumab?
Yeah, that's an interesting question, because I think Elotuzumab was clearly not lucky, because the rising star was clearly anti-CD38 antibodies, DARA and then Isatuximab. But now we can see that frontline is anti-CD38 Lendex, especially for elderly patients. And at time of disease progression, while on anti-CD38 Lendex, I think Elopomdex could be now a good solution for those patients, because Salomon said we have PVD, we have some options, but in DARA refractory patients, we need combo, and Elotuzumab is another target. And maybe now, I think our future for elderly patients is first relapse patients, 80-year-old with DARA refractory, LEN refractory disease. And the use of carfilzomib is not very easy in this population of patients. So why not Elopomdex? So I think there is an issue for access to Elotuzumab in our countries. But yeah, this is a good question. And I think, for example, in patients that failed DARA Lendex, Elopomdex could be a good option.
Excellent. Thank you very much, Cyril. Well, I mean, there are several questions, and I was trying to avoid them, but they keep on coming about the role of allotransplant in the young and fit patient, especially if there are high risk at the era of CAR T cells or bispecific. And several colleagues asked them. The last one which popped onto my screen is from Dr. Daniele Avenoso. I think Daniele is at King's College in London. Hi, Daniele. He's always very loyal to the ICH webinars. Yeah, I mean, in our practice, I don't think we're offering allo anymore to the patient. But at the end of the day, it's, I would say, the first version of the immune therapy concept, but it was non-specific immune therapy. So that brings me to the cellular therapy topic that was the last session of the IMS Congress. And my question for you, Aurore, is whether you see CAR T cells replacing auto-transplant. Again, someone would jump in and say, okay, there are two trials ongoing being randomized. So what are your thoughts today, given what we know about the results of CAR T cells in the relapse refractory setting? And how are they going to move up in the lines of treatment?
So I didn't perform any allo transplant for the first.
No, yes, I think we agree. We will not debate the role of allo tonight.
And regarding CAR T, yes, I think it will be even more efficient if we use in patients who didn't have been exposed to many drugs. So we are expecting a very good efficacy in less advanced patients. So we will see first the results of KarMMa-3 and CARTITUDE-4 trials. And we heard just the press release of KarMMa-3, and it seems more efficient than standard regimen. So we are waiting for these results. And regarding the front line, I think it will be very fast, and we are very excited for the results of CAR T in frontline. But I don't know if CAR-T can cure all patients, and if high-dose melphalan, it is my Toulouse field, will be disappear in the next future.
Okay, so let me be provocative, because I think it's always good to look into the data, but maybe try to anticipate the future. So Nizar, assuming you have access today to everything, irrespective of any label, and if you have a high-risk cytogenetics, young and fit patient with deletion 17p or whatever 1q, 1p abnormality, when, if it is the case, would you propose CAR T cells? And you can use it, everything is available and free. How do you position this in a scenario, in a futuristic scenario?
That's an excellent question, and there's a philosophical answer and there's realistic answer. The philosophical answer: immune therapy, in principle, should overcome high-risk disease driven by intracellular drivers, so 17p deletion, CDKN2A mutation, for example, because there you assume that the cytotoxicity is coming from an outside event, is independent of the resistance mechanism within the cells. And hence the premise of immune therapy. Now, the data from what we have so far with high-risk disease is a bit mixed bag. There is some data suggesting, if you look at the forest plot from the various CAR T cell therapy, that yes, some of the high-risk do as good, but the numbers are small. So the interval, the hazard ratio interval crosses 1, but close to 1. The recent data from the CARTITUDE data suggests that patients are relapsing less than 15 months, or the median PFS for patient high risk from the CARTITUDE is around 15 months versus the more than 27 months we're seeing with the CARTITUDE. So the current data suggests that the CAR T may improve the outcome of high-risk patient, but not necessarily eliminate that, which is really surprising to me, because I thought this is one way where we can overcome the 17p deletion and the 414 high risk or so. But unfortunately, the data doesn't seem to suggest there's a complete win. But again, like we've seen with Elotuzumab before, it does improve the outcome, but necessarily eliminate that. So I guess this is my philosophical answer with some realistic taste into it. I think the future is going to be with some sort of continuous therapy or continuous immune therapy, if I may, in the sense that if you can vaccinate those patients against their immune cells, and by vaccinate, what I mean, as we do with allotransplant, you induce some phenotypic T cell to expand and persist and target different variable epitope in these tumor cells. You can likely allow these patients to remain longer in remission. And we've seen some evidence of phenotypic T cell expansion, and with CAR T cell, actually, with bispecific antibodies as well as CAR T cells, suggesting that maybe this is one way you can sustain the remission longer for these patients. So I know I'd like to answer your question in a diplomatic way without giving a yes or no, but this is the real data we're facing.
Well, you are always very elegant in the way you answer, Nizar, but I think the message was there. Jean-Luc, you would like to comment on this? We can't, you have to activate your sound, yeah.
Yeah, I would like to ask a question regarding the role of CAR T in frontline, and especially in the field of transplant-eligible patient. There are trials, and there is a CARTITUDE-6 trial and the EMN trial, which aim at replacing autologous transplantation by CAR T, which is certainly a very good idea. But my question is that in this particular trial, lenalidomide maintenance is programmed. So I would like to know your opinion regarding the use of maintenance after CAR T cells. And there are different trials which are designed with CAR T followed by maintenance. Is it feasible? Is it useful? Maybe Nizar, Salomon, you can answer this question.
Yeah, and I think this is very important, because we always claim that CAR T cells are single shot treatment and then wait and watch. And now we would like to propose maintenance therapy. So Salomon.
Yeah, so we start to have some data. It's very preliminary, but there are some trials, as you mentioned, like for example, Karma7 has studied this. And we can say that we have some experience in clinical practice, because even though there is, of course, no label, no approval here, sometimes people are using it. I think especially in patients who are not reaching MRD negativity after CAR T-cell, and you think that you perhaps need an extra boost. So it seems to be doable. You need to wait a little bit for the patients to recover in terms of cytopenias. So it's somewhere around 3 months after infusion of CAR T-cell, 2 to 3 months after infusion of CAR T-cell that you can start a maintenance treatments. Of course, there's this rationale for IMIDs, lenalidomide or pomalidomide, that they will perhaps boost a little bit the CAR T-cell because they induce the expression or secretion of IL-2 and the cytotoxic T-cells. So perhaps you can improve a little bit the efficacy of those CAR T-cells. So far, it seems to be doable in terms of cytopenias. Difficult to say if it has an interest. Maintenance versus no maintenance. We will need randomized trials probably to see if it truly has an added value. But it's an interesting track. And of course, as we mentioned, we need to think that sometimes we need fixed duration of treatments. So perhaps we need to target some specific subset of patients, for example, the one who don't reach MRD negativity after CAR T-cells.
Superb. Thank you very much, Salomon. We have almost reached the end of this webinar, and it has been really a fascinating discussion. So I have one question to all of you, and you have 1 minute each to give our audience, our colleagues, your take-home message from the IMS Congress, because you all attended this beautiful Congress. Obviously, in a couple of months, we'll get new things at ASH, and of course, we'll organize a post-ASH as usual. But what is your take-home message for the community? Something that has really impacted you from your visit to Los Angeles, beside, of course, a great organization, and congratulations to the IMS leadership for really putting together this lovely event. So we'll start with you, Aurore, ladies first.
I would say that I think time has come. We have to adapt to personalized treatments, and first today to adapt to MRD.
Excellent. Cyril?
I think the work presented by Nizar team was, I think, very exciting, because we have those great new therapies such as CAR-Ts and bispecifics, and we still to discover the mechanisms of resistance to such immune therapies. And Nizar teams presented the results of BCMA mutations that appeared in patients treated with bispecific targeting BCMA. We have such results in patients treated with CAR-T targeting BCMAs. We know of this data with bispecifics, and I think the future is here. We have to understand the way myeloma cells escape from such immune therapies, and this work presented in the plenary session was very interesting to me.
Thank you, Cyril, and again, congratulations, Nizar. Indeed, Nizar and his team were really very nicely represented in the different sessions. So, Luciano.
Yeah, so in terms of, I think, practical terms, the impression I walk away is, I think there's greater acceptance for quadruplet and greater optimism for response-adapted therapy going forward. In terms of really the future, I think it's becoming clear that, myeloma is becoming a immunotherapy disease more and more. And I think I was going to say the same thing that Cyril said. I think the group, the work from Nizar's group was really the greatest innovation shown at the meeting. I think it's a glimpse of the future, where we have done a lot of work. People have done a lot of work in the past in genomics in myeloma, mostly to assess the notion of risk and different disease subtypes. I think the future is really deploying that technology, both in genomic but also immune profile, to start identify patients to a certain therapy, which would be kind of a more complicated version of what we do in CML. I don't, but where you identify a specific acquired alterations on the disease that allows you to choose therapy at a much greater scale, much more complex. But I think that's where the future is.
Excellent. Thank you very much. Salomon?
Yes, so I think one important communication at IMS was the one from Adam Cohen on CARTITUDE-2 cohort C. So those are patients with late relapse who were previously exposed to BCMA-targeted therapies. And actually, for the first time, we see that cilta-cel doesn't do that good in these cohorts. It was 65, I think, % of response rate. The PFS is quite short. So it's perhaps not a very optimistic message, but I think that was an important communication. And it seems that we truly will have to work on how to sequence those immunotherapies. It doesn't seem to be very easy. Cyril had presented to us Majestic-1 cohort C as well, on bispecific after anti-BCMA. And in both cases, it doesn't seem to be that easy. So we will surely need to work and to have some more correlative studies and biological research to understand how we can sequence those very important immunotherapies.
No, thank you very much, Salomon. And I think you are really highlighting the importance of real-world data and evidence, because when it comes, when you go outside clinical trials, things may become a little bit more different. Nizar, what is your take-home message from IMS?
Well, there was multiple messages. Aurora and Luciano mentioned the adaptive therapy, and really we need to start doing that more proactively and learn when can we stop therapy based on MRD, incorporate into that the high-risk features. The work from the French group and French colleagues about, again, defining high-risk subgroups is going to be essential, because I think high-risk definition is going to be dynamic based on the treatment we provide and the changing therapeutic we're providing. And as Cyril and Salomon mentioned, understanding the mechanism of resistance to immunotherapy is going to be essential for us to allow us to how to sequence these therapies and to overcome these mechanisms of resistance. But the highlight for me was really the preclinical work from the Spanish colleagues about the mouse model they've developed with the variable genetic backgrounds. I think it's going to be an amazing model, an immunocompetent mouse model, to allow us to hopefully answer some of these answers we need to answer about immune therapies in a preclinical model. But overall, all the groups doing some amazing work. It's amazing. I'll age myself, finished my training in 2020. We had back then thalidomide and transplant. To see the field, sorry, in 2000, not 2020, to see the field come that far along is really impressive. And I say it not as a slogan or as just it's really impressive to see the field move so dramatically in such a short time.
No, thank you, Nizar. I'm glad you mentioned this mouse model, because obviously if we can have at some point a mouse model that can mimic a human multiple myeloma, obviously that will make the work much easier at some point. The last word is always to our master, Professor Haruso. Your word of wisdom.
Great honor. Well, I think that there were many messages, many important messages in the 6 topics. In each of these 6 topics, there were important messages to the future. So I'd like to focus on the key word of the meeting. For me, the key word of the meeting was cure. We are speaking of cure. In each of the topics, we were speaking of cure. I had the privilege of chairing a session on the cure of myeloma. And I think that the problem is that currently we still don't know how to define cure. Is it sustained MRD negativity, and for how long? Is it the possibility of stopping treatment and living without treatment? Or on the contrary, is it living with a disease without MRD negativity? But as you said, if you have less than 80, let's say 74-year-old patient, if you give him 10 years survival in good condition, maybe it's not cure, maybe it's a priority objective. So I think what we are very encouraged by the fantastic improvements we have seen in the past 10 years and we continue to see with immunotherapy. We hope that a cure is possible, at least for standard risk patients. But I think it would be interesting to think again of the definition of cure in multiple myeloma.
Well, that is really a lovely conclusion. I mean, what's better than cure? I think this is exactly the goal of what we are doing. And personally, I think cure is living long and well, and all the rest is semantic. But we can organize a debate about cure, by the way. So we do have a lot to do, guys. I'd like to thank you all for really your wonderful contributions. Thanks to our audience. Thanks to all the questions and comments you have sent. Unfortunately, I wasn't able to take all of them because otherwise it would need us several hours to debate everything. We tried in less than 90 minutes actually to summarize 3 full, very heavy days. We used to start very early in Los Angeles and we finished quite late. But I hope you have enjoyed it. I hope that we managed to convey some messages, and please stay tuned and watch out for the ICH activities. Thank you very much, and wherever you are, please stay safe and keep well.